Thank you for the invite to come and talk about saliva. It's opened up a whole new world to me. It's been very educational. I'm not a researcher. I'm a diagnostic scientist. So what you're going to be hearing about is more to do with syndromic intellectual disability. So in particular, saliva sample shows increased technical and clinical utility over blood sampling in genetic investigation of syndromic ID. I put that down. So that's the kits that we're using, the Oral Collect. So why are we using saliva when we already have blood? It's everywhere. You know, it's easy to take. Well, sort of. So I won't go through all the different uses, obviously, you know, all that. So we introduced saliva testing in 2014 using these kits. Easy to collect. Our cohort is autistic children, children with ID. So it's very difficult to get a blood sample out of these kids. You know, much rather have a saliva kit collection. So, you know, you can do it in the home, you can do it in clinic, you can do it out in the country, and you can do interstate. We just got samples from Fiji the other week. So, and, you know, the quality is really good when they're in transport. We transport through Australia Post, and they're stable for about 2 months. So DNA yield is sufficient for microarray testing, which is what I do, and Fragile X testing, both PCR, Southern's, Prader-Willi syndrome testing, which is more of an MLPA-based test. So what's in a saliva sample? Well, what's not in a saliva sample? It's more the question. Human lymphocytes, fibroblasts, as we know, bacteria. I'm not so much interested in the bacteria. We're at the RCH, the Royal Children's Hospital, so there's a McDonald's there. So the kids tend to have a lot of bird. It was more due to chicken nuggets than anything else, I think. But, you know, obviously plant for those vegetarians out there. So 8 years of BCGS saliva microarray testing, 23,000 tests. So we've done quite a few. It sort of builds up over time, sort of unexpected. Same clinical utility as blood. Do we get the same sort of abnormality rates when we're using saliva? And also compare cases where we've done both a blood and a saliva in the same patient. Very hard to do that because these patients just want to have a saliva, they don't want to have a blood. So we got around that in a tricky way. And technically the same as blood. So we'll look at the DNA yield, quality, the failure rates as well for us. So what we found was there's no difference between the sample types for CNV abnormality reporting. So you can see it's 21%. It doesn't really change when you compare it to blood. So this is how we sort of tried to compare or find these cases where we'd taken both a blood and a saliva in the same individual. It was really just by chance. So we compared CNV detection between blood and saliva in the same individual by pooling all of our data and overlapping those databases. So 45,000 microarrays, we're probably up to about 60 or 70 now. Saliva, 21,000, blood, 23,000. And just by chance over time, because this was done over, 14 years, we had 370 cases where we'd taken both samples just by chance. 342 were non-mosaic, mostly normal. There were non-mosaic abnormal, which was 44. If I can point. Oh, yeah. So this is the interesting bit. 28 were mosaic, and they had 3 categories. So abnormal blood, but normal in saliva. So there's one of these that was a trisomy 18, low-level mosaic. We had 7 that were abnormal mosaic in saliva and blood. And then we had these 20 cases that were abnormal in saliva, but just completely normal in blood. So, which was sort of surprising. I didn't expect to see that because you'd think the saliva lymphocytes would be the same as blood, but no, quite different. So this is just to show you pictures worth 1,000 words. A mosaic case, epilepsy and syndromic ID in this child, terminal duplication of 11q, 14 megabase, so it's sort of half the size of chromosome 21. If that makes any sense to you. That's just an ideogram of a chromosome 11. Now we're looking at the bottom of chromosome 11 there, the red line's the log R, so that's the copy number. And you can see the B allele is the blue dots. So there's no change at all in the blood. So that's completely normal. You look at the saliva in the same individual, we're seeing 30% duplicated. You can see the splitting of the B allele and the log R shifts to the right. And then when you actually look at the skin fibroblast in this patient, 60% abnormal. So we're obviously detecting fibroblast cells within that saliva sample, but we're not seeing it in the blood at all. So this is just one of these cases. We've got 20 of these. So when you split them into syndromic ID and non-syndromic ID, I'll go a little bit further. Yeah, 20 cases. They're the ones in blue. So they've all got syndromic ID. So they're probably more severe. They've got ID, but they've got maybe heart anomalies, other sort of tissue involvement. The 7 that sort of spanned both non-syndromic and syndromic, and the one that was the trisomy 18 that was mosaic in blood. Oh, did I just miss something? No? Oh, yeah. So the mosaics, what are the characteristics that we saw with these mosaics? The non-mosaics were sort of pretty much half-half duplication and deletion. But when you looked at the mosaics, it was mostly duplication, so 70% there was a bias. When you look at the size, it's quite astounding. 0.6 megabase, so 600 kb, 700 kb for the non-mosaics, which sort of makes sense because they're probably meiotically produced. And then when you look at the mosaics, they were a lot bigger. They were 38 megabase, 54 megabase. So these are things that you could see on chromosomes. They were that big. And the non-mosaics were interstitial, so within the chromosome, whereas the mosaic cases were terminal, so 95% of them were terminal. So, okay, level of mosaicism versus abnormality type. So of all the CNVs, about 27% mosaicism. So we're talking about lower level that you're probably not going to detect with WES or whole genome sequencing. Trisomies were lower level of mosaicism, so that 10% level, which is what you'd sort of expect, because if they were above that 10%, that'd be pretty lethal, especially the trisomies I'm going to be talking about. Duplication, 20%, deletion, 30%. And when we did have 7 cases we could get a buccal sample on, the proportion always went up. So we're obviously detecting skin fibroblast cells within that saliva. And we had 1 heart tissue confirmation at a higher mosaicism level, and that was by FISH because it was paraffin embedded, which tends to happen with cardiac tissues when you try and get them. Trisomy mosaics. So we've got both very rare and common trisomies at very low levels. And when we did do a buccal sampling, it showed that fibroblast ectodermal involvement. Trisomy 1, never been seen before anywhere, prenatally, postnatally. You just don't see it because it's just so catastrophic. Probably in the first cell, it would not get through that. So I'd say what's happened here is we've had a trisomy 1 gain and then a correction very quickly, but it's been confined to the skin fibroblasts. This child actually had a cardiac abnormality as well, so it's probably in the heart tissue. Oh, sorry. Trisomy 7, rare. Trisomy 12, very rare. That had a heart abnormality as well. Trisomy 15, which is rare, but you do see it in combination with maternal UPD, which produces Prader-Willi syndrome. Trisomy 16, usually confined to the skin fibroblasts. And trisomy 21, which is quite common, as expected. So what are the genomic findings? In summary, no difference between abnormality rates in large data sets, so saliva versus blood. We've got that increased sensitivity of detection, 9.1% in saliva compared to blood of 0.44. Saliva mosaic CNVs are very large genomically and lethal if they weren't mosaic. Trisomies detected at lower mosaicism levels, so that's the 10%. And obviously some are very rare, trisomy 1 and trisomy 12. terminal in nature of these mosaic CNVs. So is there some sort of sister chromatid exchange going on, which is mitotic, or a mitotic recombination mechanism, which has always been bandied about, and maybe that's what's happening. And we've got that syndromic ID association. So this is evidenced by the buccal sort of conformations and the increase. So you're getting the ectodermal involvement, and that's related to the brain. So interesting trends in the data. 6 of those cases had heart abnormalities as well. So are we getting mesodermal and ectodermal involvement for heart and brain? So it'd be good to be able to test abnormal heart tissue, and we're starting to do that, and to test syndromic ID and heart abnormal patients. And we are getting a few of those samples coming through. We don't normally test cardiac cases because they don't fit with the Medicare rebate. That's for ID. So isolated heart just never gets a microarray usually, unless an institution's paying for it. 7 cases had seizures and epilepsy. So obviously there'll be ectoderm brain involvement. So it'd be good to test epilepsy syndromic ID patients. Test brain tissue. Probably laugh when we say that, but there's a lot of brain tissue out there, because when patients have epilepsy, they reduce the epileptic burden by taking out tissue. So there are actually lots of brain tissues out there. And test an epilepsy cohort. There's an Australian epilepsy project, which is currently underway for 3 years, 4,000 patients, all getting tested by saliva for some reason. So, which is good to see. 2 cases where we saw a benign CNV in blood, so just a terminal, very small deletion you wouldn't even report. But then when you looked at the saliva, there was just a huge duplication that was associating with that. So there's some sort of complex structural mosaicism going on. We just can't see what it is because it's saliva. We can't culture the cells, look at the chromosomes. We've actually got 2 more of these cases that we've found subsequently. So it seems to be some sort of complex structural rearrangements happening in a terminal fashion. Would also be good to test any previous mosaic benign blood CNVs by saliva, especially if they're terminal. So what about the quality, saliva versus blood? You can see the log dev, that's our quality metric. It's about 0.9 for blood, saliva's 0.1. So there's no difference. We actually failed samples at 0.2. So you can see no huge difference. The DNA yield and quality metrics, you do get less DNA, 4.2 micrograms with saliva compared to blood. Having said that, you can take 10 mils of blood if you really wanted to, whereas saliva, you're only going to be getting maybe a mil if you're lucky. So you're dealing with a suboptimal sample compared to blood. Concentrations that are low, probably get more of those. And failure rate's slightly higher, but then again, if it's failed, you just send out another saliva kit. There's nothing wrong with that, rather than having to take another blood sample. So yeah, slightly higher log dev, no difference in MA detection sensitivity, specificity. And what about home versus clinic? Is there any difference? You know, who's better at taking these samples? Well, there's no difference whatsoever, which just shows you, you know, a fool can take these samples, which is good. You need, you know, keep it simple. The KISS, you know, theory, which is why they're so good, these kits, and why we're using them. So, you know, we're still getting the same log dev 0.1. There's no difference whatsoever. So, you know, parents taking the samples. Actually, I think if you've got a degree, it probably makes you at a disadvantage for taking these because you think too much about it. So the less you know, the better it is, and just follow the instructions. And clinicians report the samples are easily taken, patient-friendly, certainty in sampling. I didn't really get this, so I had to question them about this. So when they take a blood sample, they write out their referral, hand it to the parents of a child with ASD, and then they go away and it never gets taken because no one wants to get a general anaesthetic to get a blood sample. Whereas with saliva, they can take it in the clinic, they can give it to the parents and they go, oh, saliva, I'll take that straight away. So they know they're going to get results back by the time they get their follow-up consultation, which is really good for them. and obviously easy to transport. I'm getting there. There is no technical quality CNV sensitivity disadvantage to performing saliva over blood sampling in CNV detection by microarray testing. Saliva provides patient-friendly and logistically easier sampling in investigations of children and adults for microarray testing. Saliva is better than blood in detecting clinically significant mosaic genomic abnormalities related to syndromic ID. And we recommend that you basically do a saliva rather than a blood if you're looking for CNVs, especially if they're mosaic. Just like to acknowledge all the patients, Professor Matt Gardner, who taught me everything about mosaics, Professor Ingrid Scheffer, to do with the epilepsy. She's the guru for epilepsy. BCGS pathology and cytogenetics. And if you want to read more about it, just go to the European Journal of Human Genetics. I think it was in the January issue. So all of this data is in there to have a look at. Thank you.